So, COPD is a super debilitating disorder. I remember during one of my clinical shifts, I was going in to talk to, or to give a COPD exacerbation patient some Duoneb, which is albuterol and Atrovent, or ipratropium bromide. Great medication combination for these patients. But I was going into the room, and I walked in on the gentleman on the phone talking to his daughter about how he was in the hospital again, and that you know how every time it happens it feels like he's going to die, and how he he didn't know how much longer he'd be around, and that he was just so frustrated with COPD and all that. And unfortunately he noticed I walked in and swiftly hung up, and I felt like it was a good opportunity to really talk to him about this disease and the condition. And what I found out is he actually hadn't smoked cigarettes his entire life, but he worked in a soap factory where he was in charge
Did you
of,
say,
you
did you
know,
say soap factory?
yeah. Uh, he he
Crazy.
used to make soap for a company out here.
Was his
Um,
name Tyler Durden?
no, no.
Oh, okay.
But
Sorry.
he was in charge of, mixing all the scent chemicals together with the fats for the soap. And basically 20 years of doing that caused him to develop emphysema and chronic bronchitis, and eventually led to him being diagnosed with COPD. He explained how it affected his lungs and his day-to-day life, and how his exacerbations have been getting closer and closer. We talked a little bit about how if he had smoked, like was so common back then, he wouldn't have made it to the age of 60 like he did. It COPD is a very debilitating disorder, and as a respiratory therapist, it's one of the ones you're going to see very frequently. COPD exacerbations are frequently found in the hospital. But with COPD, it's important to understand some of the more common substances out there today that that cause these people to develop these chronic obstructive lung conditions that will then be diagnosed as COPD later down the line.
Yeah, not even only with like COPD. I think it's interesting how much your place of employment can affect your breathing if you're not wearing the proper equipment. I remember when I was younger, I worked as a janitor, and every year we went over when to wear certain respirators and stuff like that. And I thought it was the stupidest thing as a kid. But yeah, looking back, probably should have wore some more respirators than I did.
Yeah, I get worried because back before I started respiratory school, I was an electrician, and we would do like remodels on like old homes and ripping out drywall and all sorts of nasty insulation and stuff. And I'm like, there's a good chance I probably breathed in some stuff I probably shouldn't. Hopefully, it doesn't have a long term effect on my lungs eventually.
Oh yeah, especially old buildings like asbestos and stuff like
Yeah,
that. Even like the insulation that we put in new houses, you got to be careful with because that can into your airways and cause scar tissue.
yeah.
I feel like that's another topic for another day. But with COPD, yeah, that's kind of interesting. I feel like we kind of sad, but we usually just associate it with smoking. Like you're a smoker, you probably have COPD. Um, I have a family member that has like liver problems, and occasionally they go in because they're jaundice and stuff like that, and they're usually like, "You need to stop drinking," and they've never touched a drop of alcohol. So I feel like that's another point we need to point out. Like we need to make sure we're not assuming certain things, but it's kind of hard when it's the norm.
Yeah. Well,
Like it's
I know
what we usually
people with
see.
COPD that have never smoked in their life. Farmers.
Right. Right. Like what do they call that? Like farmer's lung or hay lung or something like that.
Something
Yeah,
like that.
pneumoconiosis is the broad term for it. And while it's not an obstructive disease, it is a restrictive condition. It will likely lead to the development of emphysema, which, of course, as we discussed in the last episode, is obstructive.
Yeah,
But
and I think in the last episode we were saying COPD is usually a combination of like two of them,
mhm.
but isn't it usually like chronic bronchitis and emphysema?
Yeah, I would say 99% of the time COPD is chronic bronchitis and emphysema due to smoking.
Right, right. But um, along the lines of smoking, it's definitely cigarettes definitely have a lot of chemicals in them, and I think it's interesting to look back on the history of cigarettes. Back when they were first a thing, they promoted that they were healthy and that they helped with weight loss and all that kind of things, which I think is kind of interesting. I heard this might be a controversial topic, but why not? Let's just share it. Um, Somebody told me that breakfast actually isn't the most important meal of the day. It was a doctor that contract with Kellogg's try and get more cereal sold. I don't know how true this is, but it's an interesting story. But just because some medical advisor backed something, Kellogg's sales like skyrocketed. But I mean, who doesn't like cereal?
Well, sure. A lot of
It's
like
like it's
public
like toilet paper.
PSAs.
Who's not buying it?
uh, a lot of public PSAs like that do come from like a singular push for corporations, but it is important with any aspect of healthcare to do your proper research. Like look at where those researchers were funded, what if their study was actually conducted properly, and make sure to compare those results with other results of similar studies.
Right, but I felt like that was kind of harder back what in like the 50s and I don't know even before that, like 30s when cigarettes were like when they started adding all these extra chemicals and stuff like that to it. When it was popular, like it was more popular. We could go way back to tobacco, like when the U.S. was like settled as a country and stuff like that. But this isn't a history podcast. This is a health health podcast.
Yeah.
But with smoking and stuff like that, I feel like if you introduce anything into your lungs that isn't like air, or like as we kind of talked about with types of employment, like particulates that you can breathe in, it's not a good thing for your lungs. It
Oh,
can cause it can cause permanent damage.
absolutely. I mean, we should be just breathing in clean, slightly humidified air, but naturally humidified. Because
We're
that's what
we're
our
in Utah. What's humidity?
Yeah.
we still have some humidity. We we create it ourselves with our noses. Come on.
I know that stuff. I was just making a joke.
But it certainly, anything that isn't clean air coming into us isn't healthy, which begs the question of like how air pollution is affecting our lungs, and if the rise in air pollutants, especially here in Utah, where we have some of the worst inversions in the country, um,
Oh, definitely.
if there's a chance that we could develop some of these obstructive conditions just from air pollution.
Right.
Dude,
And
I
I like
think
that you brought
so.
up the whole air particulate in Utah. I think it was back in 2016. We had worse air than Beijing, which is like textbook for like bad breathing air.
Well, when it
Hope that
gets
makes
really
sense.
bad outside, like I can feel like in my lungs, like I can feel like an increased work of breathing. My head kind of hurts, and I can tell, myself at least.
Yeah, I feel the same way. You just feel like crap and like you have low
Yeah.
amounts of energy. But yeah, so something that's kind of popularized in like the last few years is vaping. That kind of goes along with smoking. I wouldn't say one is healthier than the other. I don't feel like vaping's been around long enough to have studies that show that. I honestly think vaping should be called like something else, like greasing, because vaping, it pretty much it makes you think that you're just breathing vapor, like water vapor. And like we were saying, that's humidity, and that's something normal that we breathe is just normal humidity. But vaping, it can deposit like fat in your lungs, um, and that's not good either because that can affect like air exchange.
Yeah, there was a girl in my neighborhood that I grew up in. She ended up in a hospital down in Salt Lake, and she was diagnosed with lipid pneumonia because of her vaping. The oils and the fats that she was supposedly not inhaling through her vaping device, it now coated her lungs, and I think she's still on oxygen support, and it's been a year because she just can't get
Yeah,
enough gas exchange going on in her body because of all that fatty substances that are now coated her lung.
That's a
right.
that's sad but fascinating. I mean, I during our big, vaping epidemic that occurred in fall of 2019 was I had a patient during a clinical rotation that was lipoid pneumonia from vaping, and he was vaping just normal standard nicotine products. It wasn't even any of the counterfeit stuff that was making headlines. These were, the vapes that were just available to the public, and he got sent to the ICU for a week and had full body crepitus, which you know was very interesting to see and whatnot. And it he ended up in the hospital for like 2 months just because he vaped so much. So I
Do you
never
guys
figured out what happened to him after he got discharged, but I imagine he's been stuck on supplemental oxygen as well.
you guys remember watching that video? In one of our classes, we were showing a video of like a younger kid, probably anywhere from 15 to 19, and he was like being interviewed after being in the ICU for like a month, and he was like put on ECMO and everything, all from just vaping.
Hmm.
Oh yeah, he was a high school aged kid. I'm pretty sure like Provo area.
Yeah.
But yeah,
Yeah, he was
like
a tall, lanky kid too, wasn't he?
Yeah.
yeah. But he came out and said if he would have known what the serious like adverse effects were, he would have never started.
ECMO is pretty serious. I mean,
Yeah.
that would change my mind. I mean, I feel bad that he didn't know, but it's probably a good thing because now more people do know that vaping really isn't just some means to quitting smoking. It's in itself just as bad and going to cause you just as much damage as smoking a cigarette, if not more, sometimes.
I want to touch on ECMO. You brought that up, Trevor.
Yeah.
I can never say what the acronym is for. Do you know what it stands for?
Extracorporeal membrane oxygenation.
There you go. Nailed it.
Yeah.
I too many big words. Okay, I have a reading level of like a 6-year-old. So, um, but when somebody's on ECMO, we can actually like we give the lungs, and if severe enough, we can give the heart and the lungs a break. It's not like a curative agent, but it helps those organs like rest and recover. It's like
Essentially, the blood is removed from the body and oxygenated by a fake lung outside of the body and then reintroduced to the body.
yeah. ECMO's usually it's not like a very big machine, but like the human body, it's just amazing. Like especially if you see someone on dialysis, like the big honking machine that they wheel in to like help someone's kidneys out. Like your kidneys are the size of your fist, and they have to bring in a machine that's the size of like I don't know a Mini Cooper almost. But yeah, so like ECMO, it's pretty awesome. Like your heart's about the size of your fist as well, and like your lungs, I don't know, they're a little, obviously they're bigger than your heart, but it's just crazy like the size of the equipment that has to be used to do the work of your normal organs. I don't know. Are you guys impressed by stuff like that? I think it's cool.
Oh, absolutely. Biomedical technology is fascinating. I mean, and it's becoming more and more compact as we learn more and more and advance these technologies. So maybe one
Look
day
at a
we'll actually have, ECMO machines that are smaller than the
Right.
organs.
look at like a dialysis machine. Those things are massive to do the work of something so small, a kidney.
Yeah, yeah, exactly.
That's why we need to
Like
invent nano machines.
Yeah.
Tony Stark, we need you to help us out here. Come on. We know you have the tech. Just make it available, okay?
Right.
So, and
But
the reason I believe that those small organs can do those jobs that we need big machines for is surface area. I mean, if you look at like the glomerulus of the kidneys, it's a ton of tiny tubes coiled over and over and over again. So you have that huge amount of surface area that we just can't get with the tubing that we use for dialysis machines. So it's like the same thing with the lungs and ECMO. You have all these tiny, tiny little capillaries and that are just kind of folded over on each other, surrounding the alveoli. So when we just can't work that small.
yeah. With vaping and stuff like that. Sorry, I'm gonna. I feel like we're getting a little off topic, but gonna go back to vaping. So yeah, like the lipoid pneumonia and stuff like that. It was kind of fun. I was a part of a group called Breathe Easy, and we went to different high schools and we taught high school kids about, or and like junior high kids about smoking and vaping. Nick, you were able to go to one of those, right?
Yes, that was actually a very fun event, and it's amazing how little literature there is actually out there on the effects of vaping still. But talking to these kids, it really was an eye opener for them on how bad cigarettes and vaping affect the body.
Oh yeah, like I think cigarettes are pretty well known for like being bad, but it was kind of crazy that how many people thought vaping was almost harmless.
Oh,
But
absolutely.
yeah, it was interesting teaching these kids and bringing up vaping and just watching some of their like their demeanor like change. And they're like, "Oh crap!" Like you could tell which ones had been vaping. And but I was like, "Don't worry, we're not going to tell your teachers or your principal or anything. Like, calm down, it's okay." But along those lines, we also wanted to kind of touch on marijuana as well because um, I feel like that's a little bit of a interesting topic to bring up in our world today, especially since it's legal in some places and not legal in others. Um, I
Yes, and
think we have.
there isn't a ton of literature about, marijuana use and the effect on the body just because of the previous regulations. In the next 5 to 10 years, I imagine we will see a surge of, you know, articles covering marijuana smoke's effect on the lungs. So, uh, basically, anything we're going to say regarding this topic is more of opinions rather than uh, like educated opinions based off of previous case studies that have to do with, tobacco smoke or, any other type of smoke. I should
I think it,
preface this.
Yeah,
it goes back to what you've previously already said is that anything entering the lungs that is not supposed to is going to cause damage.
Yeah, absolutely, and that's
right.
that's the main portion of it is, smoking marijuana absolutely will affect the lungs in some way, and it will probably be negative if I had to make a pretty good guess. So I
I don't know if I'm not the most educated person, but I would almost say between smoking, vaping, and marijuana, this is going to be terrible because I'm a like employee. But I would say marijuana is the safest. But still, like Trevor brought up again, anything that you're introducing into your lungs that shouldn't be there isn't a good thing. The only reason why I say I think it would be better than smoking or vaping is doesn't have all those additives and chemicals and stuff like that. But still, I don't think it's good for your respiratory system.
Oh, sure. It's like being next to a campfire and breathing in that smoke isn't good for you. Is it better than smoking cigarettes? Sure, but it's still not good for you.
Yeah, I always find it funny when people try. Well, I just did it, but when people try to gauge like which one's safer, but they're all none of them are good.
Sure, and that is an important consideration to have. And I do, to support your argument about, marijuana being the safest out of those three, with respect to, damage to the lungs. It does frequently, from my understanding, that marijuana that is being sold in dispensaries, we're not going to talk about the illegal um, selling and use of it, but those that are sold legally are not modified in any way with additional chemicals, is my general understanding. I could very well be wrong, of course, but that is going to be much better
That's my
than
understanding as well.
it's going to be much better than, the cigarettes that what has 10,000 different chemical additives um, to them, and then vaping that has Lord knows how much, but we frequently hear about metal filaments added to it, and all the
That's for
artificial
vaping,
oils.
right?
Yes, for vaping.
Yeah. Sorry, I kind of want to go back to vaping for a second. Like, patients that have a history of vaping, this like the fats and stuff, it develops popcorn lung, and um, that it, I'm trying to remember. Popcorn lung is just what it looks like on an X-ray, right? It's not like an actual popping noise that you hear when you do breath sounds, right?
No, popcorn lung, from my understanding, actually comes back to it's not like anything to do with the physical appearance of the lung. It has to go back to popcorn factories and the chemicals that they used in those. Uh,
Gotcha.
that were like super harmful for the lung. And popcorn lung is just basically an advanced form of pneumoconiosis.
Right. Man, popcorn factories are deadly too. Son of a gun.
Well, it's any hazardous chemical that you're breathing in. I mean, if you go breathe in liquid bleach, you're going to definitely damage your lungs, let alone everything else in your
I guess
body.
I guess I I guess I need to quit the Tide Pods. Uh,
Absolutely.
we've talked like an umbrella conversation about smoking, vaping, and marijuana. Um, Especially since cigarette smoking has been around for as long as it has. I think it's pretty common knowledge that it's harmful to you, and sadly, that information I don't feel like was obvious soon enough for people. So there's a lot of people who have started smoking, and now that they know it's going to harm them, they want to quit. That's commonly referred to as smoking cessation, and that's actually a big part of what respiratory therapists do. Is we try to give people resources that want to quit, and kind of point them in the right direction on where to find those resources.
Oh, absolutely. And our very own Drew here is our resident smoking cessation expert. As in he knows more than the others. So Drew, would you be willing to talk a little bit about smoking cessation?
Absolutely. I knew I shouldn't have done that research paper this semester. But it is, as we talked about, a lot of people, like, we know, there's so many warnings out there, like general surgeons warning about smoking and the nicotine that it and how it's addictive and how harmful it is to our body. But like we've also kind of discussed, a lot of people don't understand the severity of just putting foreign gases that shouldn't normally be in your lungs, like from vaping, marijuana usage, just anything really. And it's important for us to help educate those patients when they um, when we start to see and we know a little bit about their medical history, it's good to kind of let them know, like, hey, you do understand that this is not good for you. To help them understand the facts about it, so that way they are educated and they're not just one of those people out there thinking that vaping is so much more healthy for you, when we're seeing in clinical situations patients that are on the brink of dying because of the chemicals that they don't know they're putting into their lungs. But the things that I found out during this, during my time of doing some research on smoking cessation, there's really a lot, two or main forms of interventions that we can help the patient out with. Um, the first one I kind of want to talk about is like your physical intervention. There are many ways that we can help the patient or even our friends or colleagues quit. There's things like nicotine patches that help the patient to overcome like their nicotine, because that is the main addiction that they have when they start to smoke, is that addiction to nicotine. And those nicotine patches can help regulate their nicotine dosage without actually putting that harmful smoke into their body. And as time goes on, they can start weaning off of that nicotine patch. And the articles that I've read, I've seen with other interventions that has really helped to help patients quit smoking. But there's other kinds of ways like your nicotine gum. I've even seen nicotine spray listed a couple times. I'm not really 100% confident on what the nicotine spray is, but I have seen it suggested. But I feel like from the people that I've interviewed, the people that I've talked to, whether like friends, family, or even patients that I've talked to, as I'm taking care of them, one of the biggest things that I've noticed for them, and they've all had in common, is the emotional support. Um, because even if they are going through like getting these patches and stuff, it really comes down to stress for them. A lot of these people now smoke because it's a comfort thing. It's a habit for them when they start to get stressed out. I had an old boss of mine when I interviewed her. She said one of her biggest triggers for wanting to smoke when she was trying to quit was after work, because she worked as a nurse. And she, after coming home from, dealing with the patients, sometimes, those difficult patients or just even really high stress situations of being a nurse, as she was going home, the only thing she could think about was smoking to help relieve that stress. And so she had a friend, a really good friend, that he would call her every day at the end of her shift, and help kind of take her mind at ease, help relieve some of that stress, as well as, keep her mind off of wanting to smoke until she got home. And she said some of those emotional supports were some of the best things for her. And so when we're talking to our patients about wanting to quit, it's good to let them know like they need an emotional support system, whether it be friends, family. I've even seen some studies where they even go and talk to a therapist, and the therapist helps reorganize them or reorient them into what they're wanting to accomplish, and why, give them reasons to why they are wanting to quit. And I don't know if it's in America yet, but I have read a lot of research on stuff overseas where they even have like a text messaging service. I don't know if it's possible for us to like somehow, I don't know, subscribe to those text messaging, but it was a pretty cool case study that I read where they just sent messages out to help motivate, to help inform patients, and just all sorts of things. But the main things that I've seen through my interviews and my research is really offering that physical and emotional support for these patients, because they're, like we have mentioned, like there are some patients that just are completely oblivious to the harms that they're doing to their body. And
Yeah, I
oh, sorry.
sorry, Drew. Can I
Um,
step in real quick?
yeah, go ahead.
Sorry, I don't mean to mess up your flow, but yeah, why couldn't we start like a texting service? I know I went to an AA meeting for one of my classes, and I know they definitely have that for like Alcoholics Anonymous, and they have like, oh, what's the word I'm thinking of, like a coach or something like that, someone that
A
supports
sponsor.
you. Sponsor, that's what the word, right? Yeah, like I feel like that's a cash cow right there. Drew, you should
Yeah,
work out on that texting service thing. I think that'd
it,
be good.
it's funny you mention that because doing my research this semester, I actually once I'm done with school and everything else, I actually do want to try and develop a program or a clinic or something to help uh, patients with smoking cessation because it's really cool the people that I've seen it change their lives for the better. Like some of the damage is done and it's irreparable, but we can help prevent those patients from doing it even more. And the thing too is a lot of people I talked to, they thought it was like a victimless. I don't want to say crime because it's not a crime, but they thought it was just a victimless habit that they had. The only person they were hurting was themselves. And over time, we've come to realize that it's not. You know, people have had lung cancer because of secondhand smoke because their parent smoked or their sibling smoked, and just from that exposure of that secondhand smoke, it's like they were smoking their whole life too, even though they've never touched a cigarette in their whole life. And so it's important for us to let them know, like it's not just hurting themselves; it's hurting everyone around them. And it was cool to talk to some of the people, even at like when I did my rotation over at the Children's Hospital here in Utah. Anytime that someone comes in with their kid that's struggling because of secondhand smoke issues, like they go and talk to the parents. Sometimes it may not be appropriate because that's the last thing on their mind because their child is clearly sick enough to be in a children's hospital. But it's good for them to know that some of these illnesses that their children are presenting with could have been prevented because of smoking. If they had quit smoking and stuff, and it's good to let them know. Don't be a jerk about it, but let them know like there's ways for them to help quit this habit and live better lives, and their families will live better lives.
Well, it is interesting to see, like during clinicals, being with different therapists and observing how they deal with teaching smoking cessation. Seen some that are extremely rude. And I've seen some that are actually, it seems like they genuinely care about the patient. Um, but like my first time I was with somebody that was doing smoking cessation, they're just like, "Don't you know this is gonna kill you? Like, why don't you just quit?" And I think too many times we're not um, empathetic enough to like understand what it's like to quit a habit. I feel like we've kind of touched on this already, but I feel like this is an appropriate area to bring this up again.
Yeah, and
Yeah,
I
I
think
think it.
it's good. Oh, go ahead.
I was just gonna say, I think it does take a fine line of being like stern enough to get your point across always, and but also like very empathetic. Like you're saying these things because they are going to benefit the patient's life, literally. And so being stern, but also letting them know like you're saying it out of like a desire to improve their life, not just to be a mean person.
Yeah, and one thing that I did to kind of help with my research was I quit one of my habits this semester that I was doing because I was just super. Yeah, it was just something that helped kind of relax myself a little bit, and it was amazing that first week how hard it was, and just to try and kick it. But over time, it got easier and easier to break that habit and not think about it so much. And it really helped me to like to focus and understand the problems or emotions that come with trying to kick something like that you use for that relaxation and that stress management.
I kind of want to touch on that, Drew. I'm not going to ask you what your thing was that you were quitting, but I think that's a good mindset to have as a healthcare worker. I think there's things that we can all improve on and things in our own life that we can do to improve our own health. So I think that actually would be a good practice to recommend towards to healthcare workers, even like think of something in your life and change it for the better.
Yeah, and I think the other important part of smoking cessation to understand as well is um, people that I've interviewed, the research that I've read. I know you're probably sick of me saying that, but smoking cessation isn't something that happens overnight. It's for a lot of people, it's a long, grueling process, and they're not going to do it the first time. They may think that they're going to, but they're going to relapse more than likely. And as we start to see these patients showing up in the hospital, more and more for whatever reason, and it's like, dude, why didn't you listen to me the first time? Like, don't have that attitude. Let them know, like, it's fine. We break down a couple times, but it's important to just get back up on the horse and keep going. And eventually it'll stick. You just this time it wasn't that time, and but you got to keep trying, and be empathetic with them about it.
Drew, listening to you talk, one of my favorite like movie series is Rocky Balboa, and I think in the last movie I saw, he's like talking to his son, and he said, "Life isn't about how hard you can hit; it's about how hard you can get hit and keep going." It
Yeah, I
is
actually
that.
have that quote in my room.
Well, there you go. I love that quote.
Definitely doesn't
It's
say it as calmly as you do, Thomas. He's
he's pretty much screaming at his son, but I feel like his son in that movie is kind of a brat, but that's besides the point. But yeah, it's definitely you can't get too hard on yourself. We're definitely our toughest critics, that's for sure. Um, sorry, I don't know if you touched on this, Drew. I know you said it takes like the average person like 8 to 11 attempts to quit to actually
Right.
be successful.
Yep.
So yeah, like with that mindset, like obviously do your best, but don't beat yourself up like if you're having a hard time quitting.
and as a care provider, recognize like it's gonna take them that long. So
Right, right.
Yeah,
And
patience is
that's
definitely needed on both your side as the person coaching them through this, and from the patient. It's you need to be able to realize that yes, this will be a long process and you may have to restart it over and over and over, but the end goal should be worth it.
right. And I think it's interesting. I said 8 to 11. That's like 8 to 11 effective attempts.
Mhm.
I feel like I've heard it takes 21 days to develop a habit. It takes 21 days to break one. So let's just say that 21 days times 8. I guarantee it's going to take more than 21 days to effectively quit smoking. But let's just use that as an example. Like that's going to take a long time.
Yeah, and I think the key thing that I've seen is just to like find where like that niche, and you're not gonna find that niche the first time. You're not gonna find, and what maybe your triggers are, but as you're attempting to quit, you start to understand, okay, this is a trigger. I need to avoid this the next time. And then as that second attempt goes, you're maybe going to understand there's more triggers that you didn't realize the first time because you broke down and started smoking again. And but this time now it's this and this and this to you know you find your niche, you find ways to help yourself quit and avoid those triggers of stress to make you want to relapse and start smoking again.
Yep.
And
And
it's also hard like when you're talking about quitting smoking, like I feel like a lot of the times it's a social thing. Like essentially when you're asking someone to quit smoking, sometimes you're asking them to give up their friends or maybe even family members just so that they can quit because
100%.
you have to remove yourself from that environment to
Yeah.
be successful.
Yeah, I was talking to my boss, one of my previous bosses again, the one that was giving me some pointers and stuff about what she did. And she used to go to Wendover all the time. But now, since she has quit, she no longer goes there because she knows that she loves the smell of cigarette smoke. And where down on the casino floor, that's all you can smell is that cigarette smoke. And guarantee that if she goes there, she will start smoking again. And it's been, oh, I don't know, 10, 15 years since she's had a last cigarette, and she does not want to
I'm
break that
probably the
down.
only person in this group that actually likes the smell of cigarette and cigar smoke.
uh,
It's like nostalgia for me. Like I had a grandpa that smoked like a chimney,
take me
and
like
my best.
concerts. They remind me of like going to concerts and stuff.
I
Oh
can
yeah,
understand that from like the nostalgia point of view, but every time I get it, it just makes me sad because of that nostalgia. Because For me, it was my grandfather as well that smoked, but that was what took him was COPD and lung cancer.
Yeah. Same situation here, Nick. It definitely my grandpa's life too. But yeah, like my best friend's parents, they smoked all the time too. Um, so yeah, it just reminds me of my childhood.
And it really is important to emphasize that, a lot of smoking cessation these days is done when it's already kind of too late. The patients already have COPD, but we want to start getting it out sooner to, high school age kids that are starting to smoke and really get smoking cessation started as early as possible to limit their chances of developing COPD.
Nick, I thought it was interesting. We shared an experience with Breathe Easy, and like we had elementary schools reach out to us that wanted us to come and teach about the harms of vaping and cigarette smoking. I thought it was interesting. I mean, like I remember when I was in elementary school, we had the DARE program. We like loosely talked about drugs. Like we didn't go in detail about the effects of them. It was pretty much just drugs are bad. Here's your DARE T-shirt. And they like had to sign a petition saying we wouldn't do drugs. But I think it's interesting they want us to talk about like jewels and I don't know like the different methods of vaping and stuff like that to elementary school age kids even. I feel like majority of people start smoking like junior high, high school, like experimenting with it if that's something they want to try.
Oh yeah,
Well, I think it gets younger and younger every year.
yeah, absolutely. It's just it's similar to how smoking was back in the day. Vaping has become, that cool thing, or at least it was about a year or two ago when, the vaping epidemic really kicked off. But it it really has become this thing that's kind of marketed towards kids with those the like cereal
The
flavored
flavors.
vapes and cotton candy and all that stuff.
Yeah, like Captain Crunch Berries is a flavor. Like you're telling me that's targeted for an adult? Go
Yeah,
to hell. Like that's totally targeted towards a kid,
yeah,
which
absolutely.
it's
And
sad.
I get that, you can make the argument that yes, it is made for adults and sure whatever, but if it's primarily kids looking for those things and they see that and they think, "Oh, Captain Crunch or uh cotton candy. Oh, great. Yeah, I want to taste that. Let me do that vape." Um it it's a problem. It is
Yeah.
a problem.
But before we go back to our last topic that we want to revisit, I think the harm with vaping it may have changed since last time I researched it, but vaping like the oils and the juice and stuff like that that they use, it wasn't regulated very closely. So you could get different chemicals based off of like different brands. They have like different levels of amount of nicotine in those from like brand to brand, and they're usually rated from like a one, which is a small amount of nicotine, to a five, which is a lot of nicotine and other chemicals. But that even that amount like differs from brand to brand. Like what is a one, like a level one for one brand could be a level five with another one. That's something that I thought was pretty interesting and pretty harmful about vaping is it wasn't regulated very closely, especially like when it first came out. Like the FDA is known for like keeping us safe with food and drugs and stuff like that, but even cigarettes are like monitored and approved by the FDA.
Oh, sure. But what a majority of the problem with vaping was that the FDA wasn't the ones actually, regulating them. It was the FTC. It was the Trade
Oh,
Commission more than
I did.
the Drug Administration.
I didn't even know they were being regulated by anybody. I thought they were just left to their own devices.
No, it was the FTC was put in charge of regulating those products from a over the counter perspective. for lack of a better term, just those that were just sold at gas stations and whatnot. And it wasn't until the influx of lipoid pneumonia that the FDA really stepped in and started doing their job and really handling it, from what I understand. And I would say that currently, nowadays, those regulations are a lot stricter uh, by the FDA and FTC, and we're starting to get a lot of more like research trials done on nicotine vapes.
Right. And I think too many times, especially with like smoking, people don't think about the effects that it has on their body, or what they could progress to. Like I think with smoking, vaping, smoking marijuana and stuff like that, when you quit, I feel like it takes some time for you to see the benefit of quitting, like health wise. But for most people, or well, I don't know if most people, but for a lot of people, you can cause permanent damage. I think everybody does at some degree, but for it to be noticeable, uh, I don't know. I feel like I'm kind of rambling, but for a lot of people, I feel like they feel the permanent effects
Yes.
that could eventually progress to COPD.
So from what I understand, is that when you start feeling the effects from smoking or vaping or whatever, it's too late to get rid of those, really. Um,
Right, the permanent effects, right?
yes. The things you actually start to notice are those that will be with you for the rest of your life now.
Which sucks.
Oh,
But
absolutely.
I feel like there's a lot of diseases like that, um, like the more serious stuff, like cancer and stuff like that. When you start to feel like it's affecting you, it's almost too late for some of those cases.
Yeah, absolutely. Which is why, prevention is the key in medicine.
Yeah, and
Right.
I even remember, sorry, just talking about this, like one of our classmates when he was in that Breathe Easy program with you guys, he said that what struck him the oddest thing that he heard and about that was that one of the kids was like had that mentality that I can do this for a couple of years or however long and then just quit when I start seeing these things and my lungs will rebuild itself. But it's like once you lose those alveoli, like there's no coming back, like it's gone. And I
Things
don't know
don't
if a lot of
regenerate.
people understand that. Yeah. It's not like cutting your finger and then your skin healing. Like you now have got permanent scar tissue from whatever you've been doing and it's not coming back.
Right.
Absolutely. Well, but and COPD, to pivot topics a little bit, but not really because it still is very prevalent. But COPD is like the pretty much the common endpoint of disease presentation in smokers. I mean, um, pretty much anyone that smokes for long periods of time will likely get COPD in some form. And it's pretty interesting how it presents. One of the key signs we can see for someone in like a COPD exacerbation is what's termed as a tripod position. Um, it's actually really interesting. It's where they're hunched over forward to open their airway as much as possible. It's one of the key things we can use to diagnose COPD. Another one is most COPD patients are extremely thin. So they're kind of like paper thin skin, um, just because of that metabolism that comes with COPD. Which I believe, correct me if I'm wrong, um, COPD metabolism is affected just because of the appetite suppression from cigarettes.
I would say yes, and also just like the extra work that they have to put in to breathe. They're burning a lot more energy.
Oh yeah,
I dare anyone to eat and try to not breathe while you're eating. I bet you that's pretty much what it feels like.
It's actually a great way to put that. But yeah, so they'll present, super skinny. Of course, short of breath. On a chest X-ray, though, you can actually really tell that there's COPD just based off of the chest X-ray. Um, most of the time, you will see the characteristic barrel chest, which I believe that's when, upon inhalation, when you take the X-ray, it will normally you see 8 ribs upon inhalation, right?
Should be 9.
Should be 9. See, 8.
Yeah.
Okay, 9 ribs. But with COPD patients upon inhalation, due to the air trapping, it will be, you can see usually 10 or 11 ribs.
Yeah, it's termed hyperinflation. Like you can see past 9 ribs, which is not usually normal on a chest X-ray. But it's because of the air trapping. Like it's these patients with COPD, they have a hard time exhaling and getting like all the CO2 out when they exhale. I mean, um, that air just kind of sticks around in your lungs.
Yeah, absolutely. And the
And
main problem with COPD is that, they can't get air out.
and isn't it COPD like a example of like floppy lungs? Like they have
Hmm.
low compliance, or is it high
They
compliance?
have high compliance, but a super low elasticity.
That's it. It's been so long since I've revisited that thought of elastins and compliance, but yeah, it's the problem is not. I feel like it's not getting air into the lungs. It's that the lungs. I feel like it's better if there's that pressure when the lungs expand with that air. I just think that helps with circulation. When compared to like floppy lungs that don't necessarily inflate all the way when you take a breath in.
Hmm. Yeah, absolutely.
I hope that's right. That's just my opinion.
No, the term floppy lungs does definitely apply to COPD patients. So the main way we treat COPD is with, um, you know, supplemental oxygen to help them with, any oxygenation issues that they will likely have. But
I,
in emergent cases, pressure is a wonderful thing to treat COPD patients with.
and Nick, one thing it's real important that I never realized until I was in respiratory school is that COPD patients with oxygen, although it can be helpful, it can be very detrimental to them as well. Just because, for the listeners, when you give too much oxygen, their body starts to think it's doing all right and it doesn't need to breathe as much, and it actually will cause them to stop breathing as much. It kills their respiratory drive. So you only give at most 2 liters of oxygen to any COPD patient, just because if you give too much, they'll decrease their breathing significantly.
I think it's good to note as well that
I agree with that.
um, I think it's good to note as well though is because they've been living so long without oxygen in their body has learned how to compensate without it. And so, like, if you look at a blood gas, for those of you who are going to respiratory therapy, you'll see that their blood gas is more on the acidic side, and they have really high CO2 levels because their body has just learned to live with the lower oxygen levels. And so when we, like Trevor was saying, is give them oxygen or too much, their body just starts thinking, okay, I'm doing great. I don't need to breathe as much anymore.
I think it's interesting that you brought up the blood gas, Drew. That usually in these patients they do have a higher CO2, but their body is compensating with the bicarb being increased as well to compensate for that difference. And I agree with the like 1 to 2 liters of oxygen, but I think when we get to patients that are severe enough that they need to be on BiPAP to help bring that CO2 down, I would imagine we have the oxygen up a little higher than 2 liters.
Yes.
Yeah, I had a COPD patient on my floor that they had him on BiPAP continuously, and they had him cranked up to, I think, 15 liters of oxygen.
Yeah, but I feel like this podcast has almost turned into bashing nurses, but in my healthcare experience, I have like patients that are on the wrong type of oxygen delivery devices for the amount of flow they're on, and COPD patients are cranked up to like 6 liters and stuff like that. And I go in and I turn the oxygen down, and it's okay if they're slightly below 90% on their saturation because it's what their bodies are accustomed to now.
Yeah, absolutely. One of the big things with treating COPD patients is that shooting for a normal blood gas when they're not on a ventilator is a bad idea.
Right.
So that's a good way to throw them into distress. They're a chronic patient. So when they present um, with a emergent situation, they are going to look like they're in respiratory failure, but their pH should be within normal range. And if it's not, it's an acute on chronic exacerbation, which means it's going to look really bad for their, PaCO2, which, I mean, I've seen a COPD patient that presented in the ER after we got a gas. He had a CO2 of like 92 and his pH was only like 7.27 or something. So not quite enough to actually intubate him.
Yeah. And I think it's important that we need to like just touch on the bicarb with a blood gas. Like if it's compensated by the bicarb, we can tell that this is this patient's norm. Like it's chronic. They've been dealing with this for a long time. If they're like super acidic and the bicarb is still low, then it's probably safe to assume that this is acute, like this a rapid onset. Like it's fairly new to this patient.
Oh yes, absolutely. I mean, we're taught that like respiratory wise, the changes will affect the blood gas in somewhere around 20 to 30 minutes. Um, for bicarb, it takes
If it's a respiratory problem, yeah.
if it's a respiratory problem, but if it is well actually no, it's just any change to the respiratory system. It'll be, 20 to 30 minutes before it will be reflected on the blood gas. But
Oh,
bicarb itself changes in that as long as it's not like we're pushing a bolus of bicarbonate. It will take like it's like 3 days to 2 weeks to compensate.
yeah. It takes longer definitely for bicarb, and bicarb is associated with your kidneys compensating. I didn't know if we touched on that or not, but it's reflected by your kidneys trying to adjust for this change in someone's body.
Oh yeah, but
But with COPD especially, it's mainly I think it's grouped in like 4 stages mainly, like mild, moderate, severe, and like very severe kind of thing. So mild would be like their airflow is somewhat limited. Um, you don't notice it too much. Moderate would be it just says that their airflow is worse. So I would imagine at like moderate, maybe we have them on a little bit of oxygen, like a liter. Severe, like your airflow and shortness of breath are worse. We may even want to go to like a BiPAP at this point. Um, but like I think like as a new student, I felt like we should pretty much intubate anybody that had a terrible blood gas kind of thing. Like even if this person was close to pH of 7.25 kind of thing. In the real world, I feel like I would start them out on a BiPAP and see how they handle it because a BiPAP can help bring down those CO2 levels.
mhm.
Um, just like if we were to intubate them and take over their breathing altogether. But then it has the fourth category, which is very severe. Your airflow is limited. Your flares are more regular and intense, and your quality of life is poor. Oh, I would even say that would be considered like your exacerbation. Maybe I jumped the gun. I would say this is BiPAP level for sure.
Yeah, Absolutely. I mean, and with regards to what you're saying about using a BiPAP over, jumping to intubation, a lot of the research that we've been presented with over our time in the respiratory therapy schooling, a lot of research has pointed to bicarb as a bicarb, or not bicarb, BiPAP, sorry, um, as a viable step before intubation. Putting them on a bilevel or even like a high flow nasal cannula before you intubate them will has shown to decrease the amount of time needed on a mechanical ventilator.
or
Even
or even
even
prevent it completely from even needing to be intubated too, which is awesome because COPD patients are extremely hard to get off of
right.
mechanical ventilation intubation.
Oh yeah.
I don't know if I've seen too many COPD patients on high flow. I've definitely seen them go to BiPAP and like that method of ventilation, like non-invasive ventilation. But I feel like with COPD patients, almost that pressure is more important than delivering oxygen levels, which you can get some of that pressure with a high flow, but it's also accompanied with that oxygen. So we want to make sure we're not shutting down their drive. To get that pressure with a high flow, I think if I remember right, I think it's like for every 10 liters, you get the equivalent of like one PEEP.
Yeah, it's something like there, but they're using high flow more and more these days from my understanding just as like a preliminary treatment before, throwing them on a bilevel.
It's probably, I feel like most of the respiratory therapists that I work with, not all of them, I would say most of them have been in the business a long time. And sadly, sometimes in healthcare, we like get set in our ways. Like this is what we've always done. But we need to make sure that we're reviewing like what you're suggesting is this study showing. Like we need to make sure we're up to date on our uh, common practice.
Oh, absolutely. We need to give the best care that we can to patients.
Right.
Well, but we're going to end the episode here. I think we've covered um, everything that we should. We talked a bit
Excellent.
about, the different substances that cause COPD to develop, and how to stop using tobacco and cigarettes through the use of smoking cessation and some of the strategies there. And also just a little bit more in depth into what COPD is and how it's classified. So we hope you've enjoyed this episode of Don't Hate Ventilate, and we will see you next time.